Good evening, everyone. Today, the topic for discussion is pseudohyperkalemia. This is for especially the medicine PGs who are working in casualty and also the casualty medical officers or the MD emergency medicine residents. What is this pseudohyperkalemia? This is a very common condition. Let me start with a clinical example. In emergency, the medicine PG, especially the second years, who will be already aware of how to treat the hyperkalemia and already they know the impacts of hyperkalemia treatment. They are aware, like calcium gluconate, insulin, and they will give that beta agonist to push the potassium into cell. So, after handling multiple patients of CKD, AKI related patients who are actual hyperkalemia, they might have treated in the ward or in the ICU. What happens in the casualty as soon as some patient comes with a potassium 7 or more than 8 without even proceeding with further investigation or checking whether their actual potassium is 8 or not, they will start the treatment straight away. So that is wrong because there is a condition called pseudo hyperkalemia. What is this? Nothing but a laboratory error. There is a laboratory error because of which patient report is being shown wrong. But in the blood, actually, it might be in the normal range only. So, this is for the medicine PGs or the residents who are handling the casualty patient. Last week, there was a scenario where even for a OPD patient, every report was normal, only potassium is 7. The resident doctor ordered to get some calcium injection. So that is why whenever you deal with a case of hyperkalemia, you have to analyze why the patient might have developed. A common clinical scenario because of the kidney dysfunction, either AK or CKD. As such, hyperkalemia, if we go, it is because of the decreased excretion or increased intake or because of the cellular shift. That is about the etiology of the hyperkalemia. But commonly, what are the stuff we are saying? Kidney injury, either acute or chronic, diabetes, any drugs blocking the RAS. This is the common scenario where a patient taking telmisartan for hypertension or a patient who are on cardiac medication, which includes RAS inhibitor, including aldosterone blockers, AC inhibitors, now finrenone, any drugs which blocks the RAS inhibitors. So clinically, this is the three most common actual causes of hyperkalemia. But in the casualty, many at times you will encounter this pseudo hyperkalemia. Many at times. I hope many second year or third year medicine PGs might correlate the situation. So if we take hyperkalemia, these are all the most common causes, actual and this pseudo. Apart from this increased intake, cellular shift, and the endocrine causes, and all very rare. This is what you are going to see. So let's see why this pseudo hyperkalemia can happen. If I use some other terminology, why these false reports are coming. Okay, we have taken the sample from the patient, we have sent it to the lab, but why this report is being wrong? We will see the etiologies one by one. Why a resident should be aware about this? Because the hyperkalemia treatment, which include calcium gluconate, insulin with dextrose, have its own set of side effects. For example, a patient, all the reports are normal, hyperkalemia is because of the lab error. Why you want to give a calcium gluconate injection, which is having cardiac impact? And why you want to give a insulin? Patient might go into hypoglycemia. So that is very important. So that is why you should not harm the patient. You have to know the pathophysiology of this hyperkalemia. So the answer for this why is to avoid unnecessary harmful treatment to the patient. and you have to be aware since you are going to complete your MD and you are going to be the sole consultant responsible for the patient. That time, even a paramedic staff or laboratory person will ping you up. So this is the value. You have to be aware regarding this. Let's see why this can happen. Because of the hemolysis, it can happen of the RBCs during the sample collection. Any mechanical stress or the sample vial have been shaken violently. Nowadays, home collection is also being done by many of the labs. The person after collecting it, it goes by bike. Sometimes the person might be new, the sample might be undergoing a vigorous shake before reaching it to the lab, thereby it might cause hemolysis. But in some pathology lab, the pathologist or the a method, calorimetric method, can detect the free heme and probably a high potassium. Pathologists themselves will come to notice because of the hemolysis. They might not report it. They might ask for the repeat sample. Suppose if that report uh, interpretation by the pathologist somehow it is being missed. Probably the report might reach the patient, subsequently it might reach you that potassium value is high. So the first reason for the pseudohyperkalemia is hemolysis. Again, the mechanical stress during specimen handling led to hemolysis, again causes this. And other common causes are leukocytosis. Because of the high DLC, membranes will be very fragile, which leads to potassium leakage and causes hyperkalemia. Same with the thrombocytosis. And other common scenario in winter is a low temperature or the delay in processing the sample. Some pathology lab might be waiting for some more samples to come so that they keep all of the sample in a particular tray and put it in the machine. By the time there might be some delay or there might be delay from the collection center to reach the lab. For example, a person given the sample in a clinic where the lab is not there and the person is taking into the lab where there is a significant time delay. There also potassium will go high because of the low temperature. What is the mechanism? The sodium potassium ATPase in the cell somewhat goes for malfunction or dysfunction and it releases the this shift won't occur and the potassium might leak out because of which the potassium might be high and this might be the MCQ purpose. They might ask why this is low temperature causes hemolysis and these mechanisms they might ask you. But apart from this, these are all the common causes. Clinically, what we have seen most commonly is the hemolysis because of the mechanical stress, and the other being the low temperature. And there are certain labs which use the cutoff of this total count in a CLL and scenarios where TLC is very high. That time there will be some asterisk mark saying the potassium might be wrongly high. These are the things they usually mention. So this is regarding pseudo-hyperkalemia. Pseudo-hyperkalemia is nothing but lab error giving potassium value more than 5.5. As such, hyperkalemia is potassium more than 5.5. Pseudo-hyperkalemia means it is because of the lab error or the why this can happen. I told you the scenarios and when to consider this. For example, when to consider, for example, a patient is a case of CKD, potassium is so high, creatinine is so high, potassium is so high. Obviously, you have to look at the ECG, look for the ECG signs, and the patient might be an actual case of hyperkalemia. But when to consider this could be a pseudohyperkalemia if there is no ECG changes, when the urea creat is normal and the patient is not on any drugs. If these scenarios are there and potassium is high, 99% it could be pseudohyperkalemia only. Not even drugs. A person whose kidneys are functioning absolutely fine, unless there is any renal artery stenosis or something like that, drugs even won't cause because the kidney takes care of itself. If ECG is normal, urea creat is normal, very high chance it might be potassium more than 5.5 might be because of pseudohyperkalemia rather than those rare syndromes. And the drugs also you can consider. Suppose a patient is on a high dose of RAS inhibitor. Yes, possible, but always look for the ECG. Always look for the changes in the ECG before confirming and starting the treatment. How to confirm? Just repeat the sample. From the same lab or different lab, just repeat it. Few students might have doubt. Sir, potassium is 8. Should I wait for the repeat sample? If ECG means there is no change, pulse and BP is normal, get on ABG, the reports will be available within 5 minutes. If there is hyperkalemia, which is very highly unlikely because there is no ECG changes, you can wait for that repeat sample to come and to decide regarding the further treatment of hyperkalemia. So this is all regarding pseudohyperkalemia. So in the casualty, you can look out for whenever you find any isolated potassium rise. Bye bye. We will see in the next video.